So whenever, let me. Are you ready, Doctor? Doc? Let me know when you're ready so I can get the ball rolling.
Okay, it says I can't share screen while you are sharing, so.
You can go ahead.
You can go ahead.
We just do segment for the introduction. So,
I can go ahead.
or just give me a moment. Let me do the formal introduction.
You let me know.
All right. So, good evening again, fellow lands. Those lands who are joining us on YouTube, a pleasant evening to you all. It's definitely a pleasure to have you all here. Lands from right across our multiple district 60A, 60B, our guests. I know we have quite a number of guests who are here, and our lands who are joining us all the way in Ghana. I want to say welcome, and it's definitely a pleasure to have you as we, bring awareness to this childhood cancer. And without any further ado, as we have a wonderful evening planned for us, I'm going to ask our chairperson of the Cancer and Awareness Committee to do the formal introduction of our presenter this evening.
Thank you so much, Lan Chef. Ladies and gentlemen, good evening. I'm Nicole Hanson, the chairperson, Cancer Awareness and Action Committee of the Lions Club of Mona. And September is designated Childhood Cancer Awareness Month to bring awareness to childhood cancer, which remains the leading cause of death by disease for children under the age of 14. So we thought it important to bring awareness to these diseases that has affected our country's children. This evening, I have the pleasure of introducing our guest speaker. She's a consultant pediatrician at the University Hospital of the West Indies, specializing in the care of children with cancer and other blood disorders. She did her undergraduate and postgraduate training at the university, a fellowship in pediatric hematology oncology in Ontario, Canada. She is a member of the Medical Association of Jamaica, the Pediatric Association of Jamaica, and International Pediatric Oncology Association. She participates in research at the Sick Kids Caribbean Initiative, an organization that seeks to improve the outcome of our Caribbean children with cancer. And she has been married for 19 years, a mother of 2 beautiful children, an avid reader, and a lady who believes in personal development. Ladies and gentlemen, join me in welcoming Dr. Michelle Reese-Mills.
Hi, good afternoon, everyone, and thanks for that kind introduction. I am so happy to be here because I'm always happy when I meet a group that shares my passion, and childhood cancer definitely, in terms of overcoming this, is definitely my passion. So I'm really happy to be here, and I hope this presentation will help to maybe guide a little bit more in terms of where you want to have your impact with respect to this disease. I'm going to try to play this. I have a couple of videos of some of my patients that have been through the experience. These videos were actually done for a previous fundraiser. And Unfortunately, when we actually were at the fundraiser, we weren't able to play them, but let me see if it will work at this time.
Dr. Mills?
Yes.
All right, so we're not hearing.
Oh, you can't hear. Oh.
No, when you just click at that more that you're seeing when you're sharing the screen, probably at the top, and there should be an option that says share computer audio.
That says.
So hover at the top and you see a drop down.
A drop down, and I'm looking for.
More to the right.
Yes, more,
And then share computer audio.
Share computer sound. Okay, I see that. Okay. Thanks. I'm glad you said that because I am not technological at all.
Hi, my name is Cheryl Davy Marshall.
Hi.
Did you hear that?
Christoph Marshall.
Yes.
Christoph, as you know, is a cancer survivor. He has been in remission for 6 years, 6 really great years, and we are grateful. We are very grateful as a family. I'm grateful as a mom. There are no words to tell you what I felt inside, but I'm just so grateful that it really didn't turn out that way. The message that I would like to leave with parents who are going through this and who have gone through it is that you be strong. Get your family support, get your church support, trust God, trust your doctors, listen to your doctors, ensure that whomever is sick takes the medication, as my daughter would say, on time. Ensure that you research for yourself, know what it is about, be in the know, and don't ever at any time take it lightly, because it is a very, very deadly disease. And I want to say a very, very extra special thank you to the Jamaica Medical Association, whom initiative it is to partner with the oncology, if I may say, department. It's a great move. They've had support, but they could use more. They need more support and then some. So I want to say thank you for seeing it necessary to be a part of, wanting to support so that there are persons who will benefit and can benefit. And I lift my hat to you. Kudos to you and all the doctors at University Hospital for your effort and for your initiatives. And God bless you in your endeavors. Have a wonderful night. Bless you. Hi.
Okay, and then I'm going to play this one, which is just showing the teen experience.
Hi, my name is Renacia Thomas. I'm 16 years of age. I attend Dimona High School. I was being diagnosed with Wilms tumor last year, 18 of August. And I was diagnosed with cancer August 2018. I made it through the journey with the help of God and my mother. My mother is always there by my side, praying without a father. And persons in Jamaica, they're always praying, and family members are there by my side to help me out. And the doctors are there to let me feel comfortable, and my mother makes me feel like I'm the world to her. When she cries, I cry. When I cry, she cries. And I cry in front of her. She just like, she's my world. She's like my world. My message for others is to keep praying, trust in God, read your Bible, do not leave, do not back down, because God never give up on you, so do not give up on God. So my mother pray all the while. I pray too, but you don't have to like pay attention to what you're going through. I had suicidal thoughts, and that, I don't know, my mother was there pushing me and telling me that that's not right. I always ask, why me? But then again, God has plans for you in the future. He does these things. Sometimes you're saying that it's the devil, but no, I know God had this planned out for me, and I know my reasons. My mother knows this reason too. So just hold on to the faith and let God pull you through. Do not just ask God to hold on to you, because if you ask to hold on to God, you might let go, and if He holds on to you, He will not let go of you. And I also want to thank the Jamaica Medical Foundation for choosing the University Hospital of the West Indies for helping out children with cancer. Hi.
Okay, sorry. So I just wanted to share that with you in terms of just giving you the patient's perspective. Both kids are still doing quite well. So we're going to move into the more formal portion of the presentation. So I'll be talking about what the definition of childhood cancer, what's the epidemiology, the different types that are seen, what are some of the side effects of childhood cancer treatment, how should you monitor these children after, and then just an idea of what local activities we have going on for this month. So when we talk about childhood cancer, strictly speaking, we're talking about cancers that occur between birth and 15 years of age. Not to forget the older teens, you will see other definitions that encompass ages between 0 to 19 years of age. So it all depends on the reference that you're looking at. Why there's a little bit of a distinction is the types of cancers change throughout life. So cancers under 14, you have a different proportion, different type. And as you get into the older teenage years, there is gonna be some overlap with adult type cancers. So cancer in children is relatively rare as compared to adults. Worldwide, you're going to have about 300,000 children being diagnosed yearly. The US data indicates that about 15.3 per 100,000 kids will be diagnosed per year. Our local data indicates that on average, we'll have about 7.9 per 100,000. Now, practically these figures in terms of what they translate to. So I had put out an article in the paper recently that stated about 74 children per year are going to be diagnosed with cancer. And that number is going to vary a little bit. Some years it may be 50, 60, but it's going to be around that number. So as compared to when we think of adult data, so why we say that it looks relatively rare as compared to adult cancers, because when you look at the incidence, it's going to be around like 440 adults per 100,000 that are going to be diagnosed per year. So you can see that there is that bit of the variation that's there. But very important to know about, and we'll come to that in a couple other slides. So childhood cancer, in terms of the types, as I mentioned, very different, but also the effects of treatment. You can push treatment in kids versus adults. Adults have a lot of comorbidities. So, you know, they'll have the hypertension, there'll be the diabetes, other things that may prevent you from pushing the mark in terms of giving the doses of the treatment, whereas in children, we definitely try to go all out to see if we can cure. Now, the other thing that we talk about with pediatric cancers is that it's not generally caused by what we call modifiable risk factors. So there are things that will put you at risk for developing cancer. So you have genetic or chromosomal changes that occur within different cells. So you have these cells that may escape the usual immune system of the body, and you know, they just replicate. But there are other things that can cause DNA damage that are not necessarily intrinsic. So for adults, as we talk about smoking with lung cancer, oral cancers, drinking as well, eating red meat, all those things that you can control to decrease your risk of getting cancer. But for children, it's more looking at the DNA changes, which is something that's not generally modifiable. So you'll hear us say that pediatric cancers are generally not preventable, and therefore we rely on things like early detection to help us to catch the cancer at an early stage so that we can make optimize the child's outcome. So this is a slide that's just talking about causes of death in children between 1 and 14 years of age. And if you look, the accidents have the biggest section or pie. accounting for 37% of the causes. However, cancer accounts for 12% of this, and so cancer is often spoken about as the leading cause of non-accidental death in children under 14 years of age. So again, important to recognize and to know about. The other thing is there's a discrepancy that's found in the outcome of childhood cancer, depending on where you are in the world. So if you are in the US or Canada and diagnosed with a particular type of cancer, your outcome will likely be better than if you're born in, well, I guess Jamaica or another low or middle income country, because obviously resource constraints, the investment that people or government make with respect to cancer will influence how well a child does. So you can have the same disease in two different parts of the world, but your outcome is going to be different. So if we had all the resources and if we could do everything, then you would find that, you know, in the majority of cases, childhood cancer probably would be curable. So we know that early diagnosis is key, especially, you know, children who have solid tumors. When we talk about solid tumors, we talk about those that have the lumps and bumps. So the amount of treatment that you need will vary depending on if you catch the disease early or if you present late. This is something that we are working on locally right now. We recognize that, again, so we're not talking about trying to prevent, unlike for the adults, we are trying to pick up the disease at an early stage. So we recognize that there are delays in a child presenting to the treatment center that they need to go to get appropriate treatment. So from the time that the child's symptoms start, for the parents to recognize that something is wrong is where the first delay may occur in this, you know, first area where it says patient delay. Then coming into contact with a healthcare professional who may not necessarily recognize that, you know, recognize that there's a problem, but you're not quite sure if where this problem is to go. So sometimes the patient, you know, may get told to come back in a couple of weeks or put on some sort of treatment, etc., so that you have that first contact and then they're not sure. So there's a referral delay that occurs. So the first time that they present to a tertiary care center in, you know, like in our setting, then usually a couple months have gone. Then by the time you've done the biopsy and waiting on the results, you have maybe another month that has gone. And then by the time you've diagnosed a cancer, we're talking now 3 months, and by that time there's a risk definitely of it spreading. So it may have moved from a stage 1 to say a stage 3, hopefully not a stage 4, but sometimes it does happen. And then, so you have the treatment delay. So we are actively working on getting the message out, both to, so basically we're saying that everybody has the responsibility. So the parents have to recognize, you know, non-medical people have to recognize what are, in general, what the signs or the symptoms look like. And then we are also trying to educate doctors, not oncologists, because, you know, in terms of the oncologists, there's myself and my counterpart at Bustamante as to pediatric oncologists. We have other adult specialists as well, but as a population, we are small. And so we have to rely on, you know, the first responder or the doctors, the nurses, you know, to recognize that something is wrong so that the child can be referred appropriately and present at an early stage. So there are complications that can occur if you have delayed diagnosis. So definitely what we see is that the children present as emergencies. So they may go into renal failure. They may have difficulty breathing. As you say, the stage may go from a stage 1 up to a stage 4. You know, you have difficulty resecting. You know, a small mass you can resect, a huge mass would be much more difficult to resect. If it's a brain tumor, then, you know, you're gonna have all these changes that can occur that you may not be able to reverse. So we need a high index of suspicion, recognizing which groups may be high risk, and recognizing some of these red flags in order to make an early diagnosis. Some of the warning signs that we need to look for will fall into 8 broad categories. A child who presents with, you know, looking pale, who may be bleeding or having bruising. If you have some unusual lumps or swellings, and I'll look at these again in a few more slides. A child who previously could do a full round of tennis, but after 5 minutes is just droopy and can't do anything, then that's, again, a big red flag. So fatigue, somebody who's having fevers, you know, losing weight, maybe sweating, different eye changes, abdominal pain or swelling. And it's the persistence of these things that's important. So it won't go away. So limb or bony pain in the chest if you're having cough, shortness of breath, or difficulty breathing. Headaches, especially occurring at night, severe vomiting, dizziness, and loss of coordination. So as a rule, you could certainly use these as broad categories. Now, just to mention, so the most common cancers that we see, and when you look at whether it's a high income country or first world center versus, you know, a low income country, you find that the leukemias tend to predominate, brain tumors, lymphomas, and then you have some solid tumors that, depending on the age, also tend to be frequent, such as the Wilms tumor, which is a tumor of the kidney, and another tumor called neuroblastoma. As we mentioned, you know, children under 14 versus the older teens, 15 to 19 years, the proportion of the types of tumors that you see are gonna be a little bit different. So for the children 0 to 14 years, their leukemias will predominate. Again, the CNS tumors, the others that we had mentioned before. And for the 15 to 19s, you'll see lymphomas tend to predominate, you know, over the testes, and the bony tumors are what we see in the older kids as well. So I included this slide. This is information from the Children's Oncology Group, which is a consortium throughout the United States and Canada. So they group their data, so you have different centers where children with leukemia get treated at, but they group their data in order to present their outcome. So this very first slide that's here in pink at the bottom, where it says 1968 to 1970. And if you go all the way to the top where it says 2006 to 2009, what this data is showing you is that the overall survival for kids with cancer, has improved over that period of time. So this type of curve starts with all the kids, meaning at 100%. And every time you lose one, then the curve goes down. So you could see in the 1960s, they weren't doing so well, because from that 100%, we would be dropping all the way down to, say, 10%. Coming up to 2006 to 2009, then the curve just kind of gently drops a little bit, but still up to 90%. So doing much better, and it also continues to improve as we go along. However, we mentioned that the outcome in resource challenged areas tend to be a lot less than in the resource replete areas. So in areas like Namibia, the outcome were down to 37%. Central America and the Caribbean, about 48% of kids will survive up to 5 years post-diagnosis. In Japan, we are around 58%. So these are older data, I'm sorry. For Central America and the Caribbean, I don't think things have changed that much. So in terms of acute lymphoblastic leukemia, it's the most common childhood tumor. It's a cancer in which the bone marrow makes too much of these immature cells. This is a type of cancer that does get worse quickly if it's not treated. Little is known about the cause of it, but it is importantly the most curable childhood cancer. There are two main types that we talk about: the acute lymphoblastic type, the acute myeloid type. Important to know about, they're treated differently, different types of drugs, different lengths of treatment. You do have some predisposing factors where you have kids who may have immune deficiencies. The child who was in the first slide, the first video, he had Down syndrome. Children with Down syndrome are much more predisposed. They have 10 to 20 times the risk of developing leukemia, and that risk is usually within the first 3 decades of life. So really, this is what it tends to look like. We have a predominance of these cells. It tends to be like when we look under the slides, we see a lot of these immature white cells are more of a monotonous infiltrate that we see. And in terms of what the children with leukemia tend to experience, it's really related to the fact that the bone marrow is not functioning. We have these cells that don't carry out the normal function, so we don't have enough red cells. So the kids feel tired, they look pale. Because the white cells are not functional, they tend to get fevers. They don't have the platelets, which cause clotting, and so they tend to bruise easily. They tend to bleed. Because the abnormal cells are within the center of the bone, there's this abnormal pressure sensation that they get. So they get this bony pain. You touch them and they wince touch them over the bony area because of the pressure within the bones. So they get that bone or joint pain. And because you tend to have the proliferation within the hematopoietic system as well, then you get these painless lumps that they can get in the neck, under the arm, stomach, or groin. Overall, they just don't feel well, and you tend to have loss of appetite occurring with it as well. They can present as an emergency, so a very high white cell count, which infiltrates into different organs. The fevers can be an issue, so a really bad infection, or they can present with these nodes that are just really big within the chest. In order to make a diagnosis of leukemia, you have to do what is called a bone marrow aspirate, and so usually the children are put to sleep, and just like going into the middle of, we're essentially sucking out the middle of like a chicken bone. You can picture that. So this is what we take. It looks just like blood, but it has all of the blood-making cells. Put it on a slide to make a diagnosis. So the average child with leukemia usually has a good prognosis, but they have to be on treatment for about 3 years. Usually they are more intensely in hospital for the first 4 months. Right now, the total cost of treatment will be over the 3 years about 4.5 million Jamaican dollars. That's all dependent on where they're treated, though. This is just the realistic cost, meaning that if they are at a public center, then if they're covered under the whole no user fee, etc. So realistically, they won't feel that at the university hospital because we are considered a semi-private institution, then the upfront cost has to be paid. So this is just a treatment over the 3 years. So usually they have to pay a certain amount per month, coming up to anywhere between maybe 100 to 200,000 Jamaican dollars per month. However, the good thing is that if the leukemia does come back, there are options for further treatment, unlike some of the other cancers. So another important set of cancers, the lymphomas, these are the cancers that begin in the lymphatic system, what people call wax and canal. There are 2 types, the Hodgkin lymphoma, non-Hodgkin's. The Hodgkin lymphoma is the one that often is very curable. When we talk about non-Hodgkin's, it's a Hodgkin, anything that's not Hodgkin's is non-Hodgkin's. So it could be a whole, there are many other different types of lymphomas that are just lumped under that blanket. So Hodgkin lymphoma is important. It accounts for about 6% of cancers. People who have immunodeficiencies have higher risk. And there's a virus that is strongly associated with called Epstein-Barr virus. When you look at the children, these are the children where, and it tends to be of an older age group. So definitely children who are like 8 and up. They may notice that as they look in the mirror, they just notice that they have a lot of lumps to the side of the neck, as is shown in this diagram. And they tend to be sort of grouped together. So they can have it along the neck or just in front of the collarbone. It certainly can occur under the arm and it's painless. So that's also a big clue. And then you can have the same disease occur that you see in the neck occurring in the chest as well. Other things that can happen though is that they may find that they maybe have this abnormal sweating at night, meaning that they may actually have to get up and change the sheets. They may find that there's an abnormal itching that they get. Weight loss occurs. Certainly, this very on and off fever pattern. And not everybody, but maybe in about a quarter of patients that are diagnosed with this. So usually these kids have to get scanned. So CT scans of the neck, chest, abdomen, pelvis in order to make a diagnosis and to stage. Plus they have to have a biopsy done. And then treatment usually involves chemotherapy and radiotherapy. And most of them usually have to get a PET scan because we have to see, how active the disease is at each stage of treatment. So you have the other type of lymphoma, as I said, anything that's not Hodgkin's, considered to be non-Hodgkin's. So you're gonna find that the symptoms may be similar. The location may be a little bit different, and we don't need to get into the names of the different types, but the lymph node involvement may be just more extensive. You may find it in the neck, armpits, groin, the belly, there may be more of an involvement. They can have chest pain, coughing, trouble breathing. Again, with the fever and the night sweats and unexpected weight loss. Treatment, again, chemotherapy. If the radiotherapy may also have a role, and if it comes back, it tends to connote poor prognosis. So there are specific tumors that can occur in the tummy as well, especially in the younger child. So for the neuroblastoma, which tends to be, a disease of the nerve cells, then, you have a child that tends to be very irritable. You may find it gets skin involvement, where the skin has this blueberry muffin appearance. The eyes may, because the tumor is behind at the back of the eyes. Then you find an appearance that looks like raccoon eyes. There may be some degree of wasting. If I were to do an X-ray, then you'd see these little calcifications on the film. For the child with the Wilms tumor, which is the tumor of the kidneys, so this is the one that in a young child around 3 or 4 years, mom might notice that when they're bathing the child, they feel a hard lump in the belly. Sometimes when they go to lift the child, they notice one side of the abdomen tending to just be protuberant or just to look higher than the other side. Again, it tends to be painless. So you'll hear that feature over and over, you know, with the malignancies that, you know, it's a lump that, you know, you weren't quite sure what it was, but there was no pain associated, etc. Sometimes you can get a high blood pressure. Sometimes, you know, with the kidney tumors, you can have, you know, notice some sort of bleeding, especially when the kids go to urinate. Some abnormalities with the eyes and the tongue as well. Another important one is the osteosarcoma, where you have tumors occurring of the bone. So the ends of the bone where you have the growth plates. So you tend to find that this occurs in the teens. So the growing kids, especially the kids who are going through a big growth spurt, which is why we find that the adolescents, you often hear about the footballers. I don't know if you know, we've had a few locally that were involved in sports. And sometimes, you know, it's not quite obvious to them why they were having this pain, the swelling, and it seemed, you know, to maybe have gotten missed because they thought it was trauma associated. So it can occur usually at the ends of these bones. So the upper arm, you can get it in in the thigh or the leg, in the areas that I've pointed out here. So at the end of the different long bones, you can get swelling occurring in these areas. So pain and tenderness at different affected sites. They may not be able to weight bear, or you find that they limp. You're going to find some redness at the different sites. The duration of symptoms, you know, may be variable, and sometimes you can't pinpoint when it started. The trauma, as I said, is usually a red herring, but that's usually when, you know, they think that it was happening, but it may have been happening from before. So brain tumors are important. There are a whole host of different types. It's the most common solid tumor of childhood, you know, accounting for about 25% of all childhood cancers. You know, the majority of them will occur at the back of the brain. You'll have some of them occurring at the front of the brain. And what's important to know is that there are a variety of signs and symptoms that can occur. So the different ones that you can get, if you have a child that was previously normal but now has visual problems, you know, the vision appears blurred, they're having double vision, or just saying that they can't see from one eye, you know, they don't seem to be as sharp as they were before, they seem to be confused as they, you know, just kind of in a fog. If they had a particular type of headache before and the headache has now changed, if you find that they have a loss of sensation, or there's a problem with movement of an arm or leg, you know, the personality has changed, or if there's some behavior changes, if they have the headaches that just, you know, seem to become more severe, they can't balance as before, and especially if they have seizures, speech difficulties, hearing problems, you know, unexplained nausea or vomiting, these are all signs that, you know, you have to think about that may be a possible brain tumor. So that's the majority that I wanted to highlight. And another important thing that we need to think about is that once a child has been successfully treated for childhood cancer, what are the long-term effects that we need to think about? These are these adverse effects. So we know we've treated the children with things that have that may be toxic in one way or another. And how are we going to monitor them to make sure that we decrease the impact of these drugs? So what are these long-term or late effects? And gradually, because previously everybody would say, okay, we have to have a cure at all costs. So things have changed. It is now, how can we decrease the impact? What's the least dose I can give you to cure? And so that you are not cured of your cancer, but you don't have heart failure like, 10 years down the line. So things that we need to think about, what's happening with the endocrine function, abnormal growth, has your fertility been affected? What's happening with the heart, the kidneys? What's the risk of secondary cancers, so different cancer occurring? Could you have problems with processing or functioning, or how are you functioning? Psychological effects, reduced quality of life is also something, and is there a risk for early death? So these are things that we think through and either try to avoid, avert, or just to look out for. So after a child has been treated, then, for the first couple of years, certainly our surveillance would be to look for, is there a possible relapse that could occur? A relapse will look similar to a first presentation a lot of the time. So especially, let's take a child with leukemia, then a child who would have been well, gone back to school, doing okay, will now may start having pain again in bone or joint, having fevers, noticing these lumps in the neck, under the armpits, etc. Just loss of energy, etc. Sometimes, depending on, you have certain sites where, a particular disease may come back, like for boys, sometimes, leukemia likes to hide in the testes, so the testes may be an area that you may first notice a relapse. So once they come out of that first few years and you can now breathe a little easier, like you don't think the disease is coming back, then you're going to be monitoring more for the long-term effects. And we definitely follow them up for a pretty long time. So we need to make sure that the child is seen with the cancer type, date of diagnosis. We need to have an overview of what type of treatment they got. Was it surgery, radiation, therapy, chemotherapy? Did they get some sort of targeted treatment? And make sure that all the test results and staging information are with the patient for each visit. So they need yearly CBCs, so yearly blood counts, certainly for up to 10 years after the initial treatment. They need to have their weight and height monitored and immunization review. We need to monitor for psychosocial issues. We need to monitor for risk-taking behaviors, especially if they were treated, a child who's treated at 5, by the time they're a teen, they're not going to remember the experience. Teenagers are risks already in terms of risk-taking behavior. So a lot of counseling is needed to prevent them from doing, things that maybe teens would normally want to do, but their body would have already been aged by these chemotherapy drugs. And so they have to be very careful during that time. A lot of the drugs that we use may affect the heart. And so they need to have their echocardiograms done every few years. And then because the treatment that's given may affect a lot of the veins, we tend to use ports or central lines so that we're not sticking them all the time. So the port may stay in for maybe a year or two after treatment. And so we usually have to access that from time to time. The treatment sites in Jamaica, so there are 4 main areas that treat children with cancer: University Hospital, which I'm representing, Cornwall Regional Hospital, Bustamante, and Kingston Public Hospital. And as you can see, there are various ages in terms of where children get treated. Bustamante, which is the main children's hospital, stops at 12 years though. And Kingston Public Hospital treats from 12 years up, and both University and Cornwall will treat from 0 to 18 years. Anytime we talk about children who are on active therapy for cancer treatment, we have to talk about palliative care, because we mentioned about our survival, especially in our setting. We're not where we want to be with it, and that's because, again, late presentation, drug availability, the natural disease. If the disease is aggressive, it definitely can come back, and therefore we need palliative care. We need to, if these children are not going to survive, we need to have them die a good death. So we need to ensure that we focus on their symptoms, make sure that we take away their pain, make sure that they can sleep, give them good quality of life while they're still around. I also have to mention the advancement that we've made with our treatment due to our association with the Hospital for Sick Children in Toronto, Canada, where I had received some of my training. So this partnership that we have is spearheaded by Dr. Victor Blanchette, who is an oncologist who was born originally in Canada, in Barbados, but who was the lead physician for hematology oncology at the Hospital for Sick Children for many years. A child that he had treated in Barbados who did very well, the family decided that they wanted to give back to the Caribbean and donated some money towards this cause. And he has partnered with different physicians in these islands. So it's a partnership between essentially Canada, Jamaica, Barbados, Bahamas, Trinidad, St. Vincent and the Grenadines, and St. Lucia. So in Jamaica, there are 2 oncologists. Barbados, there are currently 2. Bahamas, there's 1. In Trinidad, there is 1. So we and St. Vincent and St. Lucia have pediatricians with options to refer to the other islands. Why this partnership is important is that what it has done is to help to build capacity in the region. So we've had a training of now, I think it's 37 oncology nurses. We have trained 3 oncologists, pediatric oncologists that is. What we do is we discuss cases in terms of giving advice. We also send the samples up to them, because part of the limitations that we have locally is that we don't have a lot of the resources sometimes to make the distinction between different cancers, and so we can send slides to them for that to happen. So we've had improvement in clinical care, we can diagnose more, we have in our registry that's been established at each hospital so we can track the outcome of the kids. And so it's been a good partnership, and it's not a forever partnership, but we've certainly made some strides, and I think we're learning a lot along the way, which is great. So I know we're probably a little pressed for time now, but this is similar to the slide that I had mentioned before in terms of the different warning signs. So you can always just, go over what are the main things that we would look for to suspect that this may be something that's cancerous. All right, I just wanted to mention at the end that in terms of our activities for Childhood Cancer Awareness Month, one of the main things that we want to do is to have a blood drive going at UE. So actually we're supposed to have, we've put it out to see if we could get some support for tomorrow, the 24th and the 28th. The blood bank can generally accommodate, say, 5 people at a time, but from 8 until I think 4. Actually, any day this week would actually be great. But so it would be wonderful if we could get some support, because obviously if we've given children all of these medications, some of which are toxic, some of which affect the bone marrow, and if they need blood and we can't give them, then it certainly is a travesty for that to happen. So we're asking for some support. So if you know of anybody that might be interested to help us out, that would be wonderful. We've also done a couple of articles talking about signs and symptoms of childhood cancer. There was one that was in the paper yesterday about psychological or psychosocial effects of cancer. So that's also something that could be read. We also have some interviews coming up with some parents and talking about their experience with cancer. There's also Wear Gold Day on the 23rd of September, where we will all wear gold to celebrate kids with cancer. So I think that's most of what I had. Early diagnosis starts with recognition of signs and symptoms. And so very important. I think that's one of the biggest things that we need to start doing more. If we get them to the tertiary center in a timely manner, then it increases their chance of survival. We know that access to best possible care is every child's right, and monitoring post-treatment is vital. So thank you for listening, and I'm happy to answer any questions that you might have. So I put up this picture this is a previous, when we could all gather before COVID. So this was another previous September when we just, did something with the kids for Childhood Cancer Awareness Month. So thanks again.
And thank you very much, Dr. Reese Mills. I tell you, it was a wonderful presentation, I must say. And I know my fellow Lions and Leos and guests would have learned a lot. And let me just say, thank you very much. Now, fellow Lions, Leos, guests, again, as Dr. Mills says, if you have questions, and those who are joining us on YouTube, if you have questions, you can post them and we will ask the questions for you. Dr. Mills, I must also say that you have the Wear Gold Day that's coming up on the 23rd. But as a district, we, started, I think last week, Friday, that we have our Go Gold Fridays. So that is something that, we have started wearing gold throughout our district, awareness, because we do have our district governor has joined us this afternoon. And one of her core areas is, the cancer awareness. So definitely we have started that. And, this session as well is a part of our awareness campaign. We have persons right across our district here in Jamaica. We have persons joining us from Trinidad. And like I said earlier to my fellow Lions, that we have persons joining us all the way in Ghana. They are 5 hours away, 5 hours ahead of us. And they have joined us for this session.
Oh, that's great.
So I have one question on the YouTube, Doc, and it says, is the treatment of cancer on any national health insurance here in Jamaica?
Well, I guess a quick answer would be no. I think one of the things that I mentioned about the early recognition, that's something that we are looking at, but we recognize that in terms of one, legislation for children with cancer. So taking things at a government level is important. Already we know that, when you get admitted to hospital, then in terms of the whole no user fee policy, so the children are covered with that. But in terms of insurance, which is another level that we could take it to, then no, that does not happen. But we are fighting for things in terms of making things better. And so it is certainly will be put on the agenda as well.
Wonderful. All right, so I'm not seeing any other question on YouTube at this time. And Lions who are here on Zoom, if you have any questions, you definitely feel free to ask. This is a wonderful opportunity. And like Doc said, if we're here in Jamaica, we have the blood drive, so let us participate and do what we are able to do from our end. All right, so I see another question. It says, let me see. How do you know when the treatment isn't working? When you have a treatment, let me just see. Oh, when do you know when a treatment isn't working? And do you have any backup treatment? That's the question that I saw on YouTube.
Okay, so because that pediatric cancer, when we talk about it's a whole umbrella of cancers, so we have monitoring that's done differently for each. So at each stage, so let's say it's somebody with what we call a solid tumor, if they have a lump somewhere, then if they get a course of treatment or 2 courses of treatment, then we repeat the scans. If we repeat the scans and the lump is getting bigger and not smaller, then we know that that treatment has not worked, and then we will switch to something else. For children with blood cancer like leukemia, then we will be monitoring their bone marrows from time to time. And if we're seeing these abnormal cells persist, then we know that that treatment is not working and we have to. So it's all about the monitoring, and we do it quite frequently. So if we have an indication that, I don't want to get into too technical details, but certainly, I'm looking for a percentage reduction. So it should decrease by 60% or, something along those lines that I'm looking for. Sometimes, I don't know if you've heard about like the PET scan. So if you do a PET scan and the area is still lighting up, or, I'm seeing that the disease is active despite what I'm doing, then that means I need to switch or change.
Cool. I have another question here, Doc. So we're all aware that COVID-19 has prevented in-person assistance. Like us Lions would definitely at times visit the Bustamante Hospital here in Jamaica. So what are other ways a service club like ours could assist? What of assistance or assistance over a period?
Oh, that's a good question. I guess it comes down to what, I guess still making use of the technology then, somehow connecting to the kids in some way, whether it, doing reading or still making your presence felt in some way. I don't know if in terms of service versus financial, because the monitoring still has to go on. And even for us at the hospital, we are talking more about, doing more teleconsultations as much as possible, because again, for the children themselves, it is being exposed to COVID for somebody with cancer is they're at higher risk. I mean, the latest study that came out showed that their risk of death was 3 times more than for, the regular child. And so we are being very careful with them as well. So I think we have to think of how to make use of the technology to connect in different ways. And again, like I said, they can't afford not to have their monitoring done on time. And so, is it a matter that, would you like to contribute to a scan? Would you like to, maybe contribute in some smaller way, but still significant?
Thank you. And I have another one here. So there are 2 actually. First one coming from YouTube is asking what percentage of children in the countries that you listed, Jamaica, Trinidad. Oh, so what percentage of those have cancer? For the ones in Trinidad, Barbados, Jamaica, etc.
What percentage? So the percentage itself is going to be small. So then, so like let's take Jamaica then. As I mentioned, that figure that I mentioned in terms of that 8.7 per 100,000. So for this year, let's say if we're expecting 74 children to be diagnosed overall for the year, but we only have, let's say, I don't know if this is where the person was going, but in terms of our population split for the kids, you're not gonna get more than, I mean, we're at 2.8 million. So in terms of the children being represented, then you're not gonna have more than maybe 900,000. Is that where the person was going? So of that number, we're looking for, I mean, I don't think we need more than 74 per year. That's a lot. But population wise, we still have, yeah, so it's going to be small. But each child dying is significant. So it's important.
I think
but let me know if that doesn't answer that question. Just let me know.
I think our final question at this time is asking, is what is the scope of clinical trials here in Jamaica, in the Jamaican setting for unresponsive treatments?
Okay, well, thanks for that question. Well, we don't. Okay, so what we do, we don't generally have a lot of clinical trials going locally. What we do have is a mechanism to try and get our children who are not doing well into a clinical trial into North America. So we will try the St. Jude Children's Hospital, or we will go through the National Institutes of Health in Maryland, because that's where the experimental treatment is available. Second-line treatments are usually very expensive, and we don't have generally the critical mass or the numbers so to enroll the kids. So if we want these experimental or second-line agents available, we usually have to end up paying for it. And so to make the drug available, we try to put them into a clinical trial where they do not have to pay, but we don't have that available locally, not currently.
Thank you very much. And I did say that was the final question, but really and truly at this time, Doc, it's a final question. We have just someone wanting to explain what is the PET scan.
Oh, so Well, the PET scan, when I refer to that is, and I guess I won't, well, the technical name for it is a position emission tomography, but essentially it's kind of like injecting a mildly radioactive drug into the bloodstream that helps to, it basically picks up areas that are very active. So there's certain normal areas in the body that tend to light up whenever you give that drug. But if you have cells that are in an abnormal, that are replicating abnormally or just in a very high state of turnover, then they are going to pick up this drug readily. And so it's not a lot of, more and more people are using it for different cancers, but the lymphomas, those were the lumps that I mentioned, it has been validated in. So that particular cancer tends to take up that drug a lot. So we'll use it to say, if the treatment is working, I've given you some chemotherapy, and I'm expecting at the beginning, if those areas had lit up at the beginning after a few cycles of chemotherapy, if I've given you the drug again, I'm not expecting to see that if you're responding to the medication. So it's used to help to monitor again if you are responding to the drug that's being given. I hope that answers the question.
Thank you so very much, Doc. And again, I know we have the official vote of thanks to come to you. But as we wrap up, I'm going to ask, or before I turn over to my team member or my fellow line member to complete the vote of thanks or to do the vote of thanks, I'm going to ask our district governor if she has anything to say, and then we'll turn over to my fellow colleague to have the vote of thanks completed. Diane Marie.
Thank you very much, Lan Siobhan. I am really, really happy that you have invited me to be part of this presentation. Dr. Michelle, I have learned so much from what you had to say. I mean, we talk about, contributing to LCIF where we can help fight pediatric cancers in places like Africa. But I'm here saying to myself, Lord, we don't have to go to Africa. We need to fight childhood cancer right within the Caribbean, right here. I'm very passionate about this part. And as a matter of fact, when you talk about 74 children, to me, that's a lot of children, that percentage is very, very high. And especially, I mean, we would be considered one of the lower to medium income countries. And as such, we don't have the resources ready to help them. And something struck me when you said that this is one of the diseases that may not be covered under private insurance policies. Is this a congenital situation? Would this be classified as congenital, or is it that the children can develop cancer at any time during the ages of 0 to 19?
Yes, they can develop it at any time. It's not usually seen at
born with.
Right, it's not usually at birth. You may have some clones, some what they find that sometimes if you look at birth, you may have a clone, or they might see something in the blood that looks abnormal, but nothing that manifests, and it's only some children that later develop the cancer. So that is generally not, and because that's so rare, it's not generally done. I just find that most parents don't have insurance for their children. So
right, but that's something we need to get out. And as Lions, I want to add my voice to Dr. Michelle in asking and encouraging the Lions of Jamaica to go out and support this blood drive. It is the least we can do at this point in time. These children need us more than ever. And if we can give back life, because we know blood is life, if we can give back some, we can, we should really grasp this opportunity to do the least that we can to give some of our substance to people who need it most. And that's what Lions do all the time. It is not my responsibility to give the vote of thanks, but Dr. Michelle, I am feeling it in my heart. I am really, really appreciative of this opportunity to sit in this. And when I say that I'm certain for all my lions and Leos who are on listening to you.
I'm so glad to hear. Thank you.
Thank you very much, Lion District Governor. And I'm going to invite, I think this should be one of my fellow colleagues from one of our Cancer Awareness and Action Committee member to do the vote of thanks.
Thank you, Lion Secretary. Good evening, everyone. I know we have had a very enlightening but reflective evening. So on behalf of Lion President Melissa Taylor and the executive team of the Lions Club of Mona, and on behalf of the Cancer Awareness and Action Committee and Committee Chair Lion Nicole Hansen, we thank our very special guest, Dr. Michelle Reese-Mills, for presenting data and insights on the most common childhood cancers. Dr. Reese-Mills, we are pleased that you are able to join us this evening as we continue to observe and recognize Childhood Cancer Awareness Month. We felt your passion, and we know you are working diligently towards improving the lives of children with cancer. We commend you for your service to pediatric cancer care. We were humbled by the reminder that over 300,000 children worldwide are diagnosed with cancer annually, and the tremendous impact these diagnoses have on individuals and families. Thank you for emphasizing the importance of access to affordable medical care in the fight against childhood cancers and the post-treatment effects. Dr. Reese-Mills, the Lions Club of Mona also thanks you for the meaningful way in which you responded to the questions from our participants, for highlighting some of the childhood cancer awareness activities to take place in September, and for encouraging us to wear gold on September 23 to celebrate children with cancer. Importantly, Dr. Reese-Mills, we thank you for doing your part to ensure that pediatric cancer does not stand in the way of our children's future. We appreciate your dedication. Finally, fellow Lions, Lion District Governor Maureen Graham, Leo's guests, and everyone who joined the Lions Club of Mona via live stream for Dr. Reese-Mills' presentation, thank you for your time and presence, and all the very best. Over to you, Lion Secretary.
Thank you very much, Lion Raquel. And as we come to the closing of the session, and actually then District Governor, the closing of our business meeting. So we had our business meeting earlier. I am going to be handing over the remainder of the session to our Lion President, Lion Melissa Taylor. And Melissa?
Thank you so much, Lion Chevron. Thanks again. Let me take the time out to extend a big thank you to our zone chair, Lion Keris Harper, Melvin Jones Fellow, Lion Cy Francis, our Cabinet Secretary Treasurer, Melvin Jones Fellow, and our District Governor, Lion Maureen Graham, Progressive Melvin Jones Fellow, for taking the time out to join our presentation on childhood cancer. It is indeed a pleasure having you all. My fellow Lions, my visiting Lions, my fellow club members, thank you so much. You could have been doing something else, you could have been elsewhere, but you took the time out to join us, and we want to extend a big thank you on behalf of the Lions Club of Mona. Dr. Reese-Mills, thank you so much. Indeed, very informative presentation. I have learned a lot tonight because I'd known before, but it was quite informative, a fantastic presentation. And thank you so much, Dr. Mills, on behalf of the Lions Club of Mona. Great presentation. And thanks again, Lions, for taking the time out to join. Really appreciate your participation. I'll just end by saying, I know we're already in the comfort of our home because it's after 8. So I'm just gonna wish everyone to have a restful night. Thank you so much. And at this point, I'm going to ask someone to move the motion for the adjournment of the meeting to end. My fellow Lions, my club members.
I so move.
Thank you, Tony.
Second.
Thank you so much, Line Deborah. Welcome, Line Debs. Thanks for joining. Thank you so much,
Okay,
Line.
no problem.
Have a wonderful evening, and thanks again for joining. Dr. Mills, I'll talk to you tomorrow. Thanks much, Doc.
Sure. Thanks for having me.
Thank you.
Okay, then. Good
Thank you.
night.
And I know, thank you. And let me just say, although we have ended this session, my fellow Lions and Leos and all the guests that are joining, you know, again, as your Secretary of the Lions Club of Mona, I'm the Marketing Communications Chair, and I serve on the District Government IT Commission, right? I just again want to thank you, and I want you all to stay tuned to our social media pages, because come next, on the 30th of September, just like this afternoon, we will be hosting another session, however, on prostate cancer. So that's the prevention and treatment of prostate cancer. So stay tuned, the links will be sent out. And again, thank you all for joining us this afternoon. Have a good day.
Thank you.
Thank you.
Good night. Hi, Line Zonja.
Hi, Lan Melissa. Hi, Lan Siobhan. Great
I didn't
job,
realize
Lan.
that my camera
Good
is not
job.
on.
Thank you very much.
Thank you so much, Line Zonja. Thanks for joining.
Proud of you guys.
Thank
Good
you.
job.
Thank you, Line Zonja. Good night, one and all.
Bye.
Bye. Thanks, Mr. Governor. Thank you.
Good
You're
night.
always welcome.
Excellent
Always
meeting, Madam
welcome.
President.
Thanks.
Hi, Land District Governor. So she's gone. Okay.